Welcome back to the deep dive. Today, we're jumping into a really fascinating clinical puzzle, one that starts with something seemingly routine.
Yeah, a well-child check. But it quickly turns into a deep dive into pediatric cardiology, doesn't it?
It really does. A listener sent in this scenario, and it's all about telling different congenital heart defects apart.
And the focus is on using a tool that's, well, incredibly powerful, but maybe a bit forgotten sometimes. Dynamic auscultation.
Exactly. So our mission today is to really master the physiology behind 6 different murmurs. We need to know why one diagnosis is right, and just as importantly, why the others are wrong in this specific case.
And it all hinges on one key finding.
Right, so let's lay it out. We have a 2-year-old boy. He's in for his standard well-child visit. Seems fine.
And the details paint a picture, right? Born full term, 40 weeks. Good birth weight, 3,100 grams, about 6 pounds, 13 ounces.
Healthy start and development.
Tracking perfectly. He's around the 70th percentile for height, 55th for weight. So, normal growth curves.
And the history. Anything remarkable there? Illnesses?
Nope. Remarkably clean, no serious illnesses, immunizations are all up to date, vitals are completely normal for a 2-year-old.
And that clean bill of health, that normal growth, that's actually really significant here, isn't it?
It's huge. It's kind of our first big filter. A kid who looks well is growing well. It suggests whatever is going on, it hasn't severely compromised things like heart failure kicking in or major pulmonary issues impacting development.
Yeah.
Not yet, anyway.
So we're likely looking for something more isolated, something that needs careful examination to pinpoint.
Exactly. It pushes the physical exam, especially what we hear with the stethoscope, right to the forefront. That murmur becomes the highest yield piece of data we have.
Okay, so let's get to that critical clip. During the exam, a pretty noticeable heart murmur is heard. The clinician then does something specific, the hand grip maneuver.
Right. Ask the little guy to make a tight fist, clench it hard, and hold it for a bit.
And the result, this is the key part. The murmur gets louder. It increases in intensity.
And that single fact, that physiological response, that's the master key for this whole differential. If you understand why that sound gets louder, you've basically cracked half the case right there.
It forces us beyond just memorizing where murmurs are heard, doesn't it?
Absolutely. It demands we understand the actual flow dynamics, the physiology.
Okay, so before we dive into the 6 possible diagnoses, let's break down the maneuver itself, the hand grip. What exactly is happening physiologically when the boy clenches his fist?
So the hand grip maneuver, or you might hear it called isometric hand exercise, it's a way we can acutely, change the hemodynamics right there in the clinic.
Isometric, meaning muscle tension without movement.
Exactly. Forceful, sustained clenching. It engages a whole bunch of muscles in the arm and hand, and they're contracting statically.
And that muscle tension must squeeze the blood vessels within them.
Precisely. That intense muscle activity causes widespread peripheral vasoconstriction. The blood vessels clamp down hard in those active muscle beds. And the immediate effect of all that clamping down, a rapid, pretty significant spike in what we call systemic vascular resistance, or SVR.
SVR, that's the overall resistance the heart has to pump against to get blood out to the body, right?
You got it. And in terms of the heart cycle, SVR directly translates to left ventricular afterload.
Afterload. The load or pressure the left ventricle has to work against to eject blood.
Perfect. So when SVR shoots up because of the hand grip, the LV afterload goes right up with it. The left ventricle suddenly has to push against much higher pressure in the aorta and the systemic circulation.
High SVR equals high LV afterload.
Got it. So that's the mechanism. Now, how does this help us with murmurs? You mentioned a kind of rule of afterload sensitivity.
Yes, and this is fundamental for mastering dynamic auscultation. It helps us split murmurs into 2 main groups based on how they react to this increased afterload.
Okay, what are the groups?
Category 1. These are the murmurs that increase in intensity with hand grip with that increased afterload.
Like in our patient? Exactly. These murmurs are typically caused by flow problems that originate from the high-pressure left ventricle. Think about it. If you crank up the pressure inside the LV even higher,
More pressure difference.
right, it forces more blood to escape, either backwards through a leaky valve that's regurgitation, like mitral regurgitation or MR, or sideways through a hole that's a shunt, like a ventricular septal defect, a VSD.
And more blood flow or faster flow means more turbulence.
Precisely. Higher pressure gradient, higher velocity, more turbulence, and boom, a louder murmur. That's why our patient's murmur getting louder is such a massive clue. It points strongly towards this category.
Okay, so that's category 1. What's the other?
Category 2. These are the murmurs that decrease in intensity with hand grip. They get quieter.
Why would that happen?
These are almost always linked to outflow tract obstructions, things that make it hard for blood to get out of the left ventricle in the first place.
Like a narrowed valve.
Exactly.
Yeah.
Like aortic stenosis, AS, which is a fixed obstruction, or something like hypertrophic cardiomyopathy, HCM, which can cause a dynamic obstruction.
So if it's already hard to push blood out past an obstruction.
And then you increase the resistance downstream with the hand grip, making the overall pressure the LV faces even higher.
It becomes even harder to eject blood.
You got it. The LV struggles even more. The amount of blood ejected per beat might go down, the velocity across that obstruction decreases, there's less turbulence, and the murmur gets softer.
Wow, okay. That's a really clear physiological split. Shunts and regurgitations get louder, outflow obstructions get softer.
That's the core principle.
So just based on the fact that our patient's murmur increased with hand grip, we can already say it's highly unlikely to be an outflow tract obstruction like AS or HCM.
Exactly. We've effectively used physiology to narrow down the possibilities significantly right from the start. Now we can go through the options systematically.
All right, let's tackle the differential. We have 6 possibilities. Let's start with the ones we just reasoned should get quieter, the outflow obstructions. First up, choice A, aortic stenosis, AS.
Right. AS is the classic example of a fixed obstruction at the aortic valve. The murmur you expect is systolic, definitely. It's usually heard best up at the upper right sternal border, the aortic area.
And the sound itself has a particular shape, doesn't it?
It does. It's typically described as crescendo-decrescendo. It gets louder as the ventricle ejects blood faster, hits a peak, and then gets quieter as ejection slows down towards the end of systole before the second heart sound, S2.
Okay, sounds distinct, but the key here is the hand grip response. We said outflow obstructions decrease.
And that's exactly what happens with AS. You increase the afterload of the hand grip, making it harder for the LV to push blood out systemically. Since the valve is already narrowed, the LV just can't generate the same flow velocity across that stenotic valves against this added systemic resistance.
Less flow, less turbulence.
So the murmur gets quieter. It decreases in intensity. Since our patient's murmur got louder, AS is out. It fails the hand grip test for this case.
Okay, AS is ruled out. Now, choice B is interesting, patent ductus arteriosus, PDA. This is a shunt, right? So shouldn't it potentially get louder?
It is a shunt, yes, between the aorta and the pulmonary artery. And you're right to think about the shunt physiology. High pressure aorta feeding into lower pressure pulmonary artery.
But that's usually wrong in these scenarios. Why? What's the catch with PDA?
The catch is the timing and character of the murmur. It's fundamentally different from what's implied in our case. The problem states the correct answer is VSD, which we know causes a holosystolic murmur. A PDA doesn't do that.
What does a PDA sound like then?
It causes a continuous murmur. This is the absolute key feature. Think about the pressures. The aortic pressure is higher than the pulmonary artery pressure throughout the entire cardiac cycle, both systole and diastole.
Ah, okay, so blood flows across it constantly.
Pretty much. During systole, the pressure gradient is huge, lots of flow. But even during diastole, when the ventricles relax, the pressure in the aorta stays significantly higher than in the pulmonary artery, so blood continues to shunt across the ductus.
And that continuous flow creates a unique sound.
It does. The classic description is a machinery-like murmur, or continuous to and fro sound.
Yeah.
You hear it best under the left clavicle, the infraclavicular area.
So our patient has a murmur described implicitly as harsh and holosystolic, starting with S1, ending with S2. That's completely different from a continuous machinery murmur.
Exactly. The timing mismatch rules out PDA immediately, regardless of how it might theoretically respond to hand grip. It just doesn't fit the description of the murmur sound itself. That's a common MCQ trap focusing only on shunt without considering the murmur's timing.
Got it. Timing kills PDA here. Okay, let's move to the other outflow obstruction type. Choice C, hypertrophic cardiomyopathy, HCM.
Right. HCM is different from AS. It's not a fixed valve problem. It's usually a genetic condition causing the heart muscle, particularly the septum between the ventricles, to become abnormally thick.
And that thick muscle can block the exit.
It can. It can lead to what's called left ventricular outflow tract, LVOT, obstruction. It's often dynamic, meaning it changes depending on conditions. A key mechanism involves the mitral valve leaflet.
How does the mitral valve get involved in an outflow problem?
It's called SAM, systolic anterior motion of the mitral valve. During systole, as blood is ejected forcefully through that narrowed outflow tract caused by the thick septum, it creates a Venturi effect, a low-pressure zone. This can actually suck the anterior leaflet of the mitral valve forward into the outflow path.
blocking the exit further. Wow.
Exactly. It makes the obstruction worse during systole. The murmur is typically mid-systolic, often crescendo-decrescendo like AS in shape, but heard maybe lower down, between the apex and sternum.
Okay, so it's an obstruction. Our rule says obstructions should decrease with hand grip. Does HCM follow the rule? It seems like messing with pressures might make this dynamic obstruction behave weirdly.
It does follow the rule, but the reason why is a bit counterintuitive, which makes it another great exam trap. The murmur of HCM decreases with hand grip.
Decreases. Why? You're increasing the pressure the LV has to fight against.
Right, and that increased afterload actually helps, in a way. When you crank up the SVR with a hand grip, the LV has to generate more force, and it tends to hold on to a little more blood at the end of systole. The end systolic volume increases slightly. The chamber is effectively a bit fuller.
Okay, a fuller ventricle.
That slightly larger volume, that slightly increased pressure distending the LV cavity, actually helps to keep the mitral valve leaflet pushed back, away from the septum. It reduces that SAM effect.
So the increased afterload makes the LV cavity bigger, which lessens the dynamic obstruction caused by the mitral valve being sucked in.
Precisely. Less obstruction means less turbulence through the LVOT, and therefore the murmur intensity decreases.
That's fascinating. So because our patient's murmur increased, HCM is definitely out.
Definitely out. We've now confidently eliminated AS, PDA, and HCM.
Okay, we've ruled out half the options based on physiology and timing. Now we're left with the conditions that do increase with hand grip. VSD, MVPMR, and maybe ASD needs a look. Let's focus on choice D, the one the outline flags as correct. Ventricular septal defect, VSD.
Perfect. VSD is the most common congenital heart defect overall, so it's always high on the list for pediatric murmur.
Yeah.
The basic problem is simple. A hole in the wall, the septum, between the two ventricles.
Left ventricle, right ventricle, and the pressure difference.
It's huge. The left ventricle is the high-pressure systemic pump. The right ventricle is the low-pressure pulmonary pump. So naturally, blood wants to flow from high pressure to low pressure, left to right, through that hole.
And that flow across the hole makes the noise.
Exactly. Because the pressure difference is so large, the blood jets across that defect at a very high velocity. This creates significant turbulence, resulting in a characteristic murmur.
What's the character?
Typically, it's described as harsh or blowing, and crucially, it's holosystolic.
Holosystolic meaning it lasts throughout the entire systolic period.
Yes, from the very start of ventricular contraction, S1, right up until ventricular relaxation begins, and the aortic and pulmonary valves close, S2. As long as the LV pressure is higher than the RV pressure during systole, that shunt is happening and the murmur is there. You can picture it on a phonocardiogram. The sound fills that whole S1, S2 interval.
Okay, harsh holosystolic, where do we listen for it?
The classic location is the left lower sternal border, LSB. You might hear it called the tricuspid area. It can sometimes radiate, but the LSB is typically where it's loudest.
All right, harsh holosystolic murmur at the LSB. Now, the final check, the hand grip response. We predicted shunts get louder. Does VSD fit?
It fits perfectly. It's the classic example. When the patient does the hand grip, SVR goes up, LV afterload goes up, the pressure inside the left ventricle spikes even higher than baseline.
But the right ventricle pressure doesn't change as much, right? Not immediately.
Not nearly as much in the acute setting. So that pressure difference across the septum, the transeptal gradient, becomes even larger.
Higher pressure difference driving the shunt.
Means more blood is forced across the VSD from the super high pressure LV into the relatively lower pressure RV.
Yeah.
More flow, higher velocity through that defect generates even more turbulence.
And therefore, the murmur gets louder, increases in intensity.
Exactly. It
Yeah.
ticks all the boxes. Harsh holosystolic character, LLSB location, and increased intensity with hand grip. That combination makes VSD the strongest diagnosis here.
Now, let's dig into some VSD nuances, things that often trip people up on exams. You often hear that smaller VSDs have louder murmurs. That seems backwards, doesn't it?
It does seem counterintuitive, but it's all about the physics of the flow. The sound we hear is turbulence caused by high-velocity flow through a relatively narrow opening.
Like water spraying fast out of a narrow hose nozzle makes more noise.
Exactly like that. A small, restrictive VSD creates a very high-resistance path. The huge pressure difference between the LV and RV forces blood through that tiny opening at an incredibly high speed, a real jet stream. That high velocity causes maximum turbulence and therefore a loud murmur.
Okay, so a loud murmur means high velocity, which implies a small hole. What about a really large VSD?
A large, non-restrictive VSD is almost like having one common ventricle. The pressures between the LV and RV can equalize much more easily because there's less resistance to flow between them.
So the pressure difference isn't as big.
Right, or it doesn't last as long.
Yeah.
The flow velocity across the defect is lower, there's less turbulence, and paradoxically, the murmur can be much quieter, or sometimes even absent in very large defects. So yeah, loud often means small and restrictive, which might actually be less hemodynamically significant initially than a large, quiet VSD.
That's a critical point for interpretation. Okay, another important concept. The long-term risk if a significant VSD isn't corrected Eisenmenger syndrome. What happens there?
Eisenmenger's is the end-stage complication of a large, long-standing left-to-right shunt, like a VSD or PDA.
Yeah.
All that extra blood being shunted into the pulmonary circulation year after year puts immense strain on the pulmonary arteries.
High pressure, high volume.
Exactly. Over time, this causes damage. The pulmonary blood vessels remodel. Their walls thicken, they become stiff. This is pulmonary hypertension. The resistance in the pulmonary circulation starts to rise dramatically.
Until eventually.
Eventually, the pressure in the right ventricle and pulmonary artery becomes so high that it equals and then exceeds the pressure in the left ventricle and systemic circulation.
So the pressure gradient reverses.
It reverses. The shunt flips. Instead of left to right, blood starts flowing right to left from the high-pressure pulmonary side across the VSD into the systemic circulation.
And that means deoxygenated blood is getting into the body.
Precisely. That's Eisenmenger syndrome. Deoxygenated blood from the right ventricle bypasses the lungs and goes straight out the body, leading to cyanosis, bluish skin, and multi-organ problems. It's a very serious, often irreversible condition.
And what happens to that loud, harsh murmur that was the hallmark of the VSD when this reversal occurs?
This is the really crucial, almost paradoxical point. The murmur often disappears or becomes very faint.
Why?
Because the thing that caused the loud murmur, that high-velocity jet of blood driven by a large pressure difference from left to right, is gone. The pressures have equalized or reversed, no large gradient, no high-velocity jet, no loud turbulent murmur.
So the patient gets much, much sicker, becomes cyanotic, but the defining physical sign, the murmur, vanishes.
Exactly. The disappearance of the murmur in this context is a very ominous sign indicating progression to severe pulmonary hypertension and shunt reversal. It's a vital concept. The loudest sign isn't always the worst prognosis, and its disappearance can be catastrophic.
Wow. Okay, really important VSD points there. Now let's look at the other possibilities that increase with hand grip. Choice E, mitral valve prolapse. MVP. This one sounds tricky because it can also get louder with hand grip.
It is tricky. MVP, and often the associated mitral regurgitation, MR, absolutely do increase in intensity with the hand grip maneuver. The physiology is similar to VSD in that respect.
How so?
Hand grip increases SVR, increases LV afterload. This makes it harder for the LV to pump blood forward out the aorta. So if the mitral valve is leaky, prolapsing, or frankly regurgitant, more blood is forced backward through that valve into the left atrium during systole. Increased backward flow, increased turbulence, louder murmur.
So the hand grip response is identical to VSD. How on earth do we tell them apart then? This sounds like a major diagnostic challenge.
Just comes down to the other two parts of the triad. Location and character. Where do you hear MVP and MR best?
That's usually at the apex, right? Point of the heart, fifth intercostal space, midclavicular line.
Exactly, the apex. Whereas VSD, as we said, is loudest at the left lower sternal border. That difference in location is usually the most reliable way to distinguish them at the bedside.
Okay, location is key. What about the sound itself? Is MVP different from the harsh holosystolic VSD?
Often, yes. Classic MVP has a very specific sound signature. It typically features a mid-systolic click.
A click. What causes that?
It's thought to be the sound of the redundant mitral valve leaflets and the elongated chordae tendineae suddenly tensing as the leaflets balloon back or prolapse into the left atrium during systole.
Okay, a click. And the murmur.
The click is often followed by a murmur that starts later in systole and gets louder towards S2, a late systolic crescendo murmur. This represents the regurgitation worsening as the prolapse becomes more severe towards the end of contraction.
So mid-systolic click plus a late systolic murmur heard at the apex. That sounds quite different from a harsh holosystolic murmur at the LLSB.
It does, however. And here's where the exam trap deepens. MVP often exists with or leads to significant mitral regurgitation, MR. And pure MR without the classic prolapse features can cause a holosystolic murmur, just like VSD.
Ah, so you could have a holosystolic murmur that increases with hand grip, and it could be either VSD at the LLSB or MR at the apex.
Correct. In that scenario, Location becomes absolutely paramount. You have to be meticulous about finding the point of maximal intensity, PMI. Is it truly loudest at the LLSB, pointing towards the septum? Or is it loudest at the apex, maybe radiating towards the axilla, pointing toward the mitral valve?
So in our case, with the information given implying LLSB as VSD is correct, that location is the critical tiebreaker against an apical MRMVP, even though the hand grip response is the same.
Precisely. The location anchors the diagnosis when the dynamic response is shared.
Okay, that clarifies the MVPMR trap. Let's tackle the final option, choice F, atrial septal defect, ASD. This is another shunt left to right, but between the atria this time.
Correct. A hole between the left and right atria. Now, the first really important thing about ASD is that the actual flow of blood across the atrial septum itself, it's usually silent.
Silent. Why? VSD is so loud.
The pressure difference between the left atrium and the right atrium is much, much smaller than the pressure difference between the ventricles. It's low pressure, low velocity flow. Not enough to generate a loud, turbulent murmur directly at the site of the defect.
So if the shunt itself is silent, why do we associate a murmur with ASD at all? Where does the sound come from?
It's an indirect effect. That left-to-right shunt continuously dumps extra blood volume into the right atrium, which then goes to the right ventricle. So the right side of the heart becomes volume overloaded.
Okay, lots of extra blood on the right side.
And all that extra blood has to be ejected by the right ventricle through the pulmonary valve into the pulmonary artery. It's this increased volume of blood flowing across a normal-sized pulmonary valve that creates the murmur.
Ah, so it's a flow murmur across the pulmonary valve caused by the extra volume from the ASD shunt.
Exactly. It's often described as a mid-systolic murmur, maybe crescendo-decrescendo, similar in timing to AS, but caused by flow, not obstruction.
And where do you hear the pulmonary valve best?
Left upper sternal border, right? Pulmonic area. Correct. Left upper sternal border, LESB. So the location is different from VSD, LUSB versus LLSB.
Yeah.
The character might be softer, more ejection-sounding than harsh.
Okay, location and character differ, but the absolute classic slam dunk finding for ASD is something else, isn't it?
It is. The pathognomonic physical finding for an ASD is a wide, fixed split of the second heart sound, S2.
Wide and fixed. Let's break that down. Why wide?
Wide? Because the volume-overloaded right ventricle simply takes longer to eject all that extra blood compared to the left ventricle. So the pulmonary valve, P2 component at S2, closes later than the aortic valve, A2 component, widening the natural A2-P2 split.
Makes sense. And why fixed? What does that mean?
Normally, when you breathe in, venous return to the right heart increases, delaying P2 closure even more, making the split wider. When you breathe out, venous return decreases, P2 closes earlier, and the split narrows or disappears. That's a normal physiological split.
But with an ASD...
With an ASD, that left-to-right shunt across the atria effectively equalizes the filling pressures and volumes between the two sides relative to respiration. Increased venous return on inspiration is offset by changes in the shunt. The net result is that the wide split between A2 and P2 doesn't really change much, if at all, with breathing. It stays wide and fixed.
That wide fixed S2 is the money sign for ASD.
It really is. If that finding were present in our patient, ASD would jump way up the list. Its absence, combined with the LSB murmur location, pushes ASD way down.
And the hand grip response for the ASD flow murmur, does it increase?
Generally much less so than a VSD or MR. Remember, the ASD murmur is due to volume flow across the pulmonary valve, driven by the chronic shunt. Acute changes in systemic afterload, SVR, from hand grip don't drastically or immediately alter that right-sided volume overload or the flow across the pulmonary valve in the same way they affect the pressure gradient across a VSD. So it's relatively insensitive to hand grip compared to VSD. Wrong location, wrong S2 finding, less sensitive dynamic response ASD is out.
Okay, this has been incredibly thorough. We've walked through all 6 using timing, location, character, and especially that dynamic hand grip response. We've eliminated AS, PDA, HCM, MVPMR, and ASD.
Leaving us pretty confident with VSD.
Yeah.
We could really nail it down with what we could call the VSD triad for this case.
Go ahead. Triad sounds memorable.
Okay, first, timing and character. A harsh, turbulent, holosystolic murmur fills that S1, S2 gap completely.
Check.
Second, location. Heard best at the left lower sternal border, LOSB. Points right at the ventricular septum.
Check.
And third, dynamic response. The murmur intensity increases with the hand grip maneuver, confirms it's sensitive to increased LV afterload, fitting that pressure-driven shunt mechanism.
Check. The triad holds up perfectly.
Those three things together in this context make VSD the clear diagnosis.
You know, the big takeaway for me listening to this is just how powerful understanding the physiology of the hand grip is. It's not just about knowing facts, it's about reasoning through the pressure changes.
It absolutely is. That's the core skill, isn't it? Forget rote memorization for a second. If you hear a systolic murmur and you do the hand grip, if it gets quieter, think outflow obstruction, AS, HCM. If it gets louder, think shunt or regurgitation, VSD, MR, maybe MVP.
That initial split, based purely on the dynamic response, cuts the possibilities right down. Then you use location and character to pinpoint the exact cause.
Exactly. That's the diagnostic algorithm in action.
Yeah.
It shows dynamic auscultation isn't some old-fashioned thing. It's real-time physiological assessment at the bedside. We use one simple maneuver to clarify a complex differential.
Brilliant. Okay, before we wrap up, you mentioned Eisenmenger's earlier. Any final provocative thought for our listeners based on this?
Yeah, just to reflect on that paradox again. We spent all this time focusing on the VSD murmur getting louder with hand grip and how a loud murmur often means a smaller restrictive defect.
Right.
But then consider the progression to Eisenmenger's. The patient develops severe pulmonary hypertension. The shunt reverses. They become cyanotic. And that loud murmur, the most obvious sign we were tracking, often vanishes.
Because the driving pressure gradient is gone.
Right. So the provocation is this. Sometimes, in cardiology, the loudest problem isn't the sickest patient. And the disappearance of a key sign can actually indicate the disease has progressed to its most dangerous stage. It forces you to integrate the whole clinical picture, not just one isolated finding.
That's a fantastic point to mull over. The sound can be inversely related to the severity in those late stages, a crucial lesson in not being falsely reassured. Thank you so much. This has been an incredibly valuable deep dive.
My pleasure. Hopefully listeners can take this approach thinking about the why behind the physical signs and apply it broadly.
Absolutely. Keep listening, keep thinking dynamically, and we'll catch you on the next deep dive.